we talked about pain theory and more to come. So I hope you use that as sort of a starting point for what's coming up. We're going to talk more about the neural mechanisms involved, really cool and interesting stuff. But don't get too bogged down in it right now. But this quarter, think about what are we doing with physical modalities? Are they affecting ascending or descending pain controls? But we're also going to talk about how we're going to assess pain in the clinic and then other methods for managing pain. So the learning objectives for this part are identify various methods of assessing pain. Where does the assessment of pain go in the SOAP note? Identify some more common pharmacological approaches to pain control. Describe how physical agents control pain and identify various non-pharmacological approaches to pain control. Lots of things. So lots of pain scales have been developed for assessing pain because, you know, the classic, oh, what's your pain? This is what they usually say, from 1 to 10, 10 being worst pain you can imagine, and or 0 being no pain. Sometimes it's hard for people to parse that in their brain. They can't figure, oh my God, I don't know, what's a 5, what's a 10. One time I had like a kind of pinched nerve or something that resolved pretty quickly, but as I was going through it, I thought, oh, so this is what 10 out of 10 pain feels like. So some people say childbirth, whatever. I've never given birth to a child, so I don't have that as a comparison. But there are lots of different ways. So one of them is visual and analog numerical scales. So where, like it shows here, put an X on this line to indicate how severe your pain is now. Still hard for people to figure out. Comparison with a predefined stimulus like childbirth or when you broke your leg or something like that is sometimes a way used to assess pain. Semantic differential scales, so word lists and categories to describe pain, and we'll look at a couple of those. Other measures can be like daily activity / pain logs, like you record your daily activity and what caused pain and what didn't. Body diagrams, open-ended structured interviews, and physical examination and testing. So this is typical body diagram where you're going to mark little different, like little scribbles for aches and little arrows for shooting pain and pins and needles and X's for sharp pain. And it allows people to draw on the little body diagram. I'm sure that some of you have seen this pain scale at the bottom. It's called the Wong-Baker Faces Scale. And it was originally used with children, but it works for adults too. So this is the Wong-Baker Faces Rating Scale. It's a pain scale that was developed to work with children, also works with adults. And it's like, how much are you no hurt face to a crying face that best describes their level of pain. And so for people that can't verbalize their pain, that might work. The semantic differential pain scale from the McGill Pain Questionnaire, it asks like really specific questions about what your pain feels like flickering, quivering, pulsing, throbbing, pricking, boring, drilling, hot, burning, etc. So people can circle the ones that in each appropriate group, you circle the one that is appropriate to you. So that gives people a little more definition. I like the Mankowski pain scale because it relates it to how long it lasts, whether or not you can ignore it, and whether or not medications have an effect on it. This is commonly used for in like workman's comp, L&I type settings. And I like this because people can define their pain better. I was working with a guy a while back who everything was 10 out of 10 pain for him. Well, he was not unconscious. The pain did not make him pass out. And so I asked him to rate his pain on this scale, and he came out at about a 7. So, I mean, that was a little more defining for him. So that kind of worked for him. The FLAC pain scale, and FLAC stands for face, legs, activity, cry, and consolability. It was developed as a method for assessing pain in children between the ages of 2 months and 7 years, or individuals that are unable to communicate their pain. When I was at Swedish Hospital in Seattle, we use this for people who were unable to communicate their pain, and it actually works really well. It's found to be accurate for use with adults in intensive care units and who are unable to speak due to intubation. And it is a little more objective, which is kind of nice. I do like that, and there's research to back it up. So basically, you get a score of 0, 1, or 2 for each of those categories, and it comes out to a score of 10. So very interesting. And that's really useful for hospital settings. There's a pain assessment in advanced dementia that was developed to provide a universal method of analyzing pain in patients with late-stage dementia. And it's similar to the FLAC scale in terms of you're looking at objectively at what's going on with them to figure out what their pain level might be. This one is just a humorous one that I like. If you're into fine art and pain scales, I have that hanging up in my office. So there's that. No, I like the Salvador Dali number 10, Not Even Human Anymore. So for pain management, the goals of care are to resolve the underlying pathology when possible, to modify discomfort and some suffering, and to maximize function within the limitations imposed by the patient's condition. Persistent pain may need integrated multidisciplinary treatment, including psychological and physiological therapies, physical agents, and exercise. So exercise is shown to be a very effective intervention for a lot of pain management. And I don't know, I always feel like I can fix everything with exercise. I don't think that's 100% true, but it's my underlying thought. So pharmacological approaches to pain management, systemic analgesics like non-steroidal anti-inflammatory drugs, acetaminophen, Tylenol, opioids, anticonvulsants, and antidepressants, spinal analgesia. So a lot of times when people are, say they're on a muscle relaxer, they're usually either anticonvulsants or sedatives. Spinal analgesia is used for intractable pain, local injections or topical analgesics. The problem with pharmacological approaches is side effects of medications. So common side effects of opioids are nausea, vomiting, sedation, gastrointestinal slowing, which can cause constipation, and respiratory suppression. So if you recall from what I said in pathophysiology, when people die from opioid overdoses, they die from respiratory acidosis because they stop breathing and they can't breathe out their CO2, and so they die from respiratory acidosis. The dangerous side effects of opioids are the most dangerous are respiratory suppression and tolerance, dependence, and addiction. So those are some bad side effects. With physical agents, commonly used types of physical agents are cryotherapy, thermotherapy, electrical stimulation, and traction. The benefits of physical agents are that they directly moderate inflammation, modulate pain at the spinal cord through that gating effect. They alter nerve conduction or increase endorphins. And when we talk about individual physical modalities, we will talk about how they do that. They also may help to resolve the underlying cause if the underlying cause is inflammation or, something that can be affected by those. It allows the patient to interact with their injured body parts and practice independent pain management skills, and that's important. If you show someone that they can have an effect on their pain, that is very, very powerful. And it avoids medication-related side effects, which is also very, very powerful. Other pain management approaches, exercise is an important component of pain management. Selecting appropriate exercises for patients with chronic pain can be challenging, but it can be done. And Love it. If nothing else works, put them in the pool. The pool is great for pain management. You start at lower level and then gradually increase the intensity. Cognitive behavioral therapy is often used to help patients cope with pain and perceive their pain as manageable. Um, an example of some of the things that are used with cognitive behavioral therapy are pacing, attention diversion, cognitive restructuring, so rethinking how you relate to the pain, graded exposure, and goal setting. So those can all be important pain management approaches. Another thing that we do in therapy that sort of is in the line of cognitive behavioral therapy that we do in PT is therapeutic neuroscience education, where we teach people about pain theory and how pain works in their body. And it's a way to give them a tool for reframing and restructuring their pain. So, comprehensive pain management programs are usually based on a biopsychosocial model. So, the focus is not on eliminating the pain, but on independence and overall quality of life. And it's a coordinated team approach, including medication adjustments, graded therapeutic exercise, and functional rehabilitation. That's usually our part. Occupational therapy to help modify their environment, and cognitive behavioral therapy. So, comprehensive pain management programs we're involved in PT, and they can be very helpful for people with chronic pain.